Welcome to the deep dive. We take these really dense sources, pull out the core stuff, and basically give you the shortcut.
Yeah, make it manageable.
Exactly. So today, we're diving into something pretty heavy, but really crucial. Early-onset psychotic disorders.
Mm-hmm.
This is all coming straight from Chapter 52 of Kaplan and Sadock's comprehensive textbook of psychiatry. We're going to extract the key frameworks, the neurobiology bits, and the clinical management stuff you need to know.
That's right. Our mission today really is to help you get a solid handle on psychosis when it shows up early, before age 18.
Okay.
And it's complex material because you're mixing standard psychiatric diagnosis with development itself. And that often means a tougher, sort of sneakier illness course.
Right. Okay. Let's unpack that then, starting with the basics, the language. Psychosis symptoms, they get split into two main buckets.
Yep, two main types. First, you've got the positive psychotic symptoms. Think of these as things added to someone's experience.
Like hallucinations.
Exactly. Hallucinations, delusions, weird sensory stuff, disorganized thinking, even catatonia sometimes.
Got it. Additions. And the other type.
Those are the negative psychotic symptoms. And these are more about a loss or a deficit.
The subtraction.
Right. So like flattened affect, not showing much emotion.
Yeah.
Apathy, not caring. Poverty of speech, or even poverty of thought content. And a really key one, avolition.
Avolition, remind me.
That's that real difficulty initiating or just sticking with goal-directed activities like making choices, starting tasks.
So if I'm hearing this right, the negative symptoms are often about what the young person stops doing. They stall developmentally, pull back socially.
Precisely. Yeah, they're often the most, insidious and damaging symptoms long-term, especially for how someone functions day to day.
Okay. And the chapter makes a point about age.
It does. A clear distinction. Early-onset schizophrenia, or EOS, that's when the positive symptoms clearly start before age 18.
Before 18.
But then there's very early onset, sometimes called childhood onset, and that's even earlier symptoms popping up before age 13.
Wow, okay. And the sources, they really stress the urgency here, don't they?
Absolutely.
It's not just managing symptoms. It sounds like it's managing a full-blown developmental crisis.
It really is. These disorders can be devastating. You see recurrent crises, schooling gets totally derailed, social growth stops.
Huge costs, personal and societal.
Massive. And the authors really emphasize this goal. The idea that early effective treatment might actually change that long-term trajectory for the better.
Which means you have to diagnose it correctly first.
Exactly. And this is where, for you, the learner, knowing the difference between the main diagnostic systems is absolutely vital.
Okay, lay it out for us. DSM versus ICD.
Right. So the DSM-5-TR criteria for schizophrenia in youth, they're pretty stringent. You need the symptoms, positive or negative, sure, but you need them for at least 6 months.
6 months.
And this is crucial. You need significant social or occupational problems, or basically a failure to hit those expected developmental milestones.
6 months and major functional impairment. That sounds like a high bar.
It is. Now, contrast that with the ICD-11. It only requires 1 month of symptoms.
Just 1 month.
Just 1 month. And importantly, it doesn't have any specific impairment criteria built into the diagnosis itself.
That seems like a huge difference for clinicians.
It is, yeah. But what's fascinating, and the chapter points this out, is that even though the formal criteria differ on impairment, researchers pretty much all agree that significant neurocognitive declines are a core feature. We're talking problems with executive function, social understanding, memory.
Okay, but if those cognitive issues aren't official diagnostic criteria in the same way, why are they so important?
Because the research consistently shows those cognitive deficits, the attention, the memory problems, those are the things that most strongly predict long-term functioning.
More than the hallucinations or delusions.
Often, yes.
Yeah.
Much more so. It tells us that our treatments really need to target function, daily living skills, cognition, not just getting rid of the voices. That's a massive takeaway for thinking about prognosis.
Absolutely. Okay, let's quickly touch on the related diagnoses, the schizophrenia spectrum. First one mentioned is schizophreniform disorder.
Right. Schizophreniform is all about duration. It looks like schizophrenia, but its short lasts between 1 and 6 months.
Only 1 to 6 months.
Yeah. And the source notes it's kind of unstable. It often ends up becoming full schizophrenia or schizoaffective disorder later on, which is probably why the ICD-11 doesn't even list it separately.
Interesting. Okay, then there's schizoaffective disorder, SA. This is where mood comes in, right? Gets complicated.
It does get muddy, yeah. With SA, you need those clear psychotic symptoms, but you also need significant periods of major depression or mania happening alongside them.
Okay.
But here's the clincher, the diagnostic rule. There has to be at least 2 solid weeks where the psychotic symptoms are present without any mood symptoms.
Ah, so a period of just psychosis.
Exactly. That 2-week window proves the psychosis isn't just, a side effect of the mood episode. It shows it's primary.
Okay. And if the psychosis only happens during a mood episode, how do we use the info, like in Table 52 to 1 the chapter mentions, to separate that out from, say, major depression or bipolar with psychotic features?
It comes down to timing. In mood disorders with psychosis, the psychotic symptoms are only there during the mood disturbance.
Only during the highs or lows.
Right. And with depression, the psychosis is often mood-congruent themes of guilt, worthlessness, poverty, things like that. And importantly, usually don't see that really disorganized thinking, that formal thought disorder.
And bipolar.
With bipolar psychosis, you look for those other bipolar hallmarks like decreased need for sleep, maybe hypersexuality, and crucially, the negative symptoms like apathy and flat affect are generally absent.
Got it. Okay, let's shift to the numbers, the epidemiology, and the why, the etiology. The chapter mentions that psychotic-like experiences are surprisingly common.
Yeah, quite common actually, transient ones anyway. In youth who aren't seeking help, the median prevalence is around 9.8% between ages 11 and 21.
Wow, nearly 1 in 10 having some kind of experience like that.
It's a big number. But, and this is the really crucial distinction, the actual diagnosis of childhood-onset schizophrenia, COS, is incredibly rare.
How rare?
The estimate is less than 0.04%. So fewer than 4 kids out of every 10,000.
Okay, huge difference.
Massive. So the big takeaway here is just having persistent psychotic experiences doesn't automatically mean schizophrenia. It's often a sign of various mental health issues, but usually not schizophrenia itself.
So if the actual diagnosis is that rare but clearly devastating when it happens, why does it happen?
The chapter frames it as a neurodevelopmental disorder.
That's the dominant view, yes. It relies heavily on this idea called the multiple hits theory.
Multiple hits, meaning?
Meaning it's likely not one single cause. It's more like a cascade. You might start with some underlying genetic vulnerability.
Okay.
Then maybe add some early problems like an infection or famine during pregnancy. And then later, maybe environmental hits like severe trauma or significantly heavy cannabis use in adolescence.
So genes plus environment, potentially starting even before birth. Exactly. Multiple factors disrupting brain development over time.
And what does that look like in the brain itself, neurobiologically?
Well, the findings point to subtle differences in how neurons connect and communicate. There seem to be issues with synaptic refinement or pruning the process where the brain cleans up connections.
Pruning, like trimming a tree.
Sort of, yeah. Getting rid of unnecessary connections to become more efficient. But in schizophrenia, that process seems to go awry, especially in areas like the frontal, parietal, and temporal cortex, the higher-level thinking areas.
Okay. Now, the chapter says something really interesting about the early onset cases specifically. It's worse.
It seems to be yes. EOS is linked to more profound neurodevelopmental disruptions. The key finding highlighted is an exaggeration of the normal cortical volume loss that happens during adolescence.
Exaggeration, meaning the brain loses too much tissue.
Essentially, yes. Adolescence is a time of major brain reorganization, including some natural pruning or thinning of the cortex. But in EOS, this process seems to be accelerated and excessive.
Where is that most noticeable?
Particularly in the cingulate, temporal, and frontal regions. This excessive loss is like physical evidence that EOS represents a more severe, earlier disruption of brain development compared to adult onset.
And that severity seems mirrored in the genetics too, right? It's not just common variation.
Exactly. While schizophrenia in general is polygenic, lots of common genes, each adding a tiny bit of risk, individuals with EOS are much more likely to have major chromosomal abnormalities, or these large, rare DNA copy number variants, CNVs.
CNVs, those are big chunks of DNA missing or duplicated?
Yes, exactly. And these CNVs carry a much higher individual risk. The most striking example the chapter gives is the 22q11.2 deletion.
That's linked to velocardiofacial syndrome, VCFS.
Right. And get this, the chapter suggests that maybe up to 10% of all schizophrenia cases might actually have VCFS.
10%? That's huge. That really flags the genetic component in early onset.
It's enormous, yeah. It really sets this early onset group apart genetically.
Okay. And turning back to environment for a second, the chapter mentions cannabis specifically.
It does. It highlights heavy cannabis use during the teenage years as a significant risk factor.
Why then, specifically?
The thinking is that the brain's own endocannabinoid system plays a really critical role in development during adolescence. Flooding that system with external cannabinoids from heavy use might disrupt those crucial developmental pathways, potentially increasing psychosis risk and leading to long-term cognitive problems.
Makes sense. Okay, let's shift to how this actually looks in a clinic. Since we're talking about kids and teens, how do the symptoms present differently than in adults?
Well, the onset is often quite insidious, can creep up over a few years.
Hmm.
And even before clear psychosis, these kids are often described as a bit odd, maybe socially awkward or having developmental delays. And these premorbid signs are often more severe than what you see before adult onset.
And when the positive symptoms do hit?
Hallucinations are often multimodal. They might see and hear and feel things. And interestingly, kids often name their hallucinations.
Name them.
Yeah, like the red sweater guy or the man with no skin. Actual examples from the text. They give them personalities.
That's quite chilling. And I guess kids don't readily volunteer this stuff.
Exactly. They rarely complain about it unless you ask them directly, very carefully. And delusions before about age 16 tend not to be these complex, systematized plots you see in adults. More often, they're kind of vague, like a general feeling that everyone is out to get me.
Understood. Now, the chapter raises a huge red flag regarding risk in this group. Suicide.
Paramount concern. Yes, the risk can be as high as 10% within the first decade of the illness.
10%.
It's tragically high. And what makes it even more dangerous is this problem of diagnostic reluctance. Clinicians are often hesitant.
Hesitant to diagnose EOS. Why more so than in adults?
Well, partly stigma, maybe unfamiliarity, but also just the sheer weight of giving such a severe diagnosis to a child. The consequences feel enormous.
And that reluctance leads to delays.
Big delays. It significantly increases the duration of untreated psychosis, the DUP. The chapter states it's about 3.5 times longer in EOS compared to adult onset.
3.5 times longer without treatment.
Yeah. And that's critical developmental time being lost while the brain is still undergoing rapid changes and potentially deterioration. It's a huge problem.
Which underlines why ruling out other things first is so critical. The medical workup mentioned, referencing Table 52.2, sounds absolutely essential.
Non-negotiable.
Yeah.
You absolutely must do a thorough neurologic exam, get an EEG to rule out seizures, maybe an MRI if there are focal signs, and extensive blood work.
Looking for what in the blood work?
Metabolic issues, autoimmune diseases like lupus, and crucially, specific antibodies for autoimmune encephalitis.
Because that's treatable differently.
Completely differently. It can be life or death, getting that distinction right.
And the chapter uses the case of Emily to really hammer this home, right? Can you describe that briefly?
Yeah. Emily's case is powerful. She was 16, sudden onset of paranoia, weird movements, problems with her autonomic system. And critically, she didn't get better with standard antipsychotics. That's a huge red flag. Turns out she had anti-NMDA receptor encephalitis, an autoimmune condition.
Ah, so not primary psychosis.
Exactly. And it was linked to an ovarian teratoma.
Yeah.
Once the teratoma was removed and she got immunomodulatory therapy, she improved. It's a stark reminder. You must rule out medical mimics.
Absolutely critical. Okay, before we get to treatment, let's quickly clarify a couple of key differential diagnoses mentioned, referencing Table 52.1 again. First, autism spectrum disorder, ASD. There's overlap in social awkwardness, right?
There can be, yes.
Yeah.
And there's even some genetic overlap. But the key things are ASD symptoms have to start before age 3. And for someone with ASD to also get a psychosis diagnosis, they need to show clear hallucinations or delusions, and there needs to be a definite change or decline in their level of functioning beyond their baseline ASD.
So a clear change.
Right. ASD itself doesn't typically involve formal thought disorder like schizophrenia does.
And PTSD. Sometimes that involves hearing voices or paranoia.
It can, yes. But with PTSD-associated psychosis, the symptoms are usually directly tied to the trauma, like reliving the event, or paranoia specifically related to the perpetrator, or themes of the trauma. It's generally much more circumscribed.
Okay, that helps clarify. Now let's talk prognosis, the long-term outlook. The chapter references Figure 52.2, and, well, the picture seems pretty grim for EOS.
It is, unfortunately. The prognosis is significantly worse than for adult-onset schizophrenia.
Not much worse.
The numbers suggest only about 5% to 25% of youth with EOS experience what we'd call good outcomes long-term. Compare that to maybe 40% in adults.
Wow, big difference.
Yeah. And the illness course tends to be more chronic, less episodic than in adults. Plus, there's that documented progressive decline in cognitive functioning that happens around the illness onset.
Which impacts real-world functioning.
Dramatically. As adults, very few individuals who had EOS manage to live fully independently or hold down full-time jobs.
Okay. So, Given that really tough prognosis, the need for comprehensive multimodal treatment feels even more urgent. What's the evidence-based approach outlined in the chapter?
It starts with pharmacotherapy. Atypical antipsychotics are the first line.
Like which ones?
Risperidone, olanzapine, aripiprazole are common ones mentioned.
Hmm.
And this is crucial in kids and teens, you have to watch side effects like a hawk.
Such as?
Well, olanzapine, for instance, has the highest risk for significant weight gain and changes in lipids. Aripiprazole, on the other hand, you worry more about akathisia, that awful inner restlessness.
So careful monitoring is key. What if those don't work?
If 2 trials of different atypicals fail, the chapter clearly states that clozapine is the drug of choice for treatment-resistant EOs. It's often more effective, but it comes with its own serious monitoring requirements.
Right. And since we talked so much about cognitive deficits predicting function, the non-drug therapies must be vital.
Absolutely essential. The focus has to be on functional improvement. Cognitive remediation therapy, or CRT, gets mentioned specifically.
What does CRT do?
It's designed to directly target those cognitive problems. Studies show it can improve things like verbal memory, executive functions, and even lead to modest gains in daily living skills. It's trying to push back against that cognitive decline.
Makes sense. And what about helping them connect back to the world, like with school or jobs?
Yeah, the sources strongly endorse supported employment, particularly the IPS model, individual placement and support.
IPS.
Yeah, it's a model focused on getting people into competitive jobs quickly with ongoing support. Studies found youth in IPS got significantly more jobs and earned more money compared to standard services. It really works.
That's encouraging.
And finally, the chapter highlights the value of specialized integrated programs, like the NIMH's RAISE Early Treatment Program. These deliver coordinated multimodal care meds, therapy, family support, employment help, all together.
And they work better?
Significantly better, yeah. Better quality of life, better symptom control compared to just usual fragmented care.
Okay. So wrapping this up, what are the absolute must-know points for our listener from this chapter?
Right, I'd say. 1, early onset psychosis is complex, often insidious. 2, diagnosis needs strict criteria adherence, especially that duration piece in the DSM and a mandatory medical workup. Rule out those autoimmune and genetic conditions.
Okay.
3, the prognosis is difficult, but early identification and integrated multimodal treatment are absolutely key to trying to lessen that deterioration. Pharmacology, CRT, IPS, they all matter.
And understanding the underlying biology.
Critical. Recognizing those neurodevelopmental aspects, like the cortical volume loss and the stronger genetic links in EOs, that's where future research needs to focus.
So we'll leave you, the listener, with this provocative thought the authors raise. If EOs, being more severe and maybe biologically clearer, serves as a more homogeneous model for understanding schizophrenia, how might targeting those specific disrupted developmental pathways, maybe even before psychosis fully emerges, lead to actual prevention strategies down the line? Something to think about.
Definitely. And on behalf of the authors, really thank you for taking this deep dive with us into the literature on early onset psychotic disorders. We genuinely hope this helped you integrate this crucial knowledge.